Okay, I'll start. Male patient, 33 years old, with right groin pain, football match trauma 9 months ago, was treated medically and physiotherapy for 3 months with still symptoms of anterior groin pain. On clinical examination, right labral stress test, Fedor test positive, and Eli test was positive for an anterior hip contraction. Plain X-rays, here a calcified rectus femoris, and with the measurements of the true CE angle was 34 and tonus angle was 8, and the lateral view, the cam angle was 72. So we go with the MRA and we diagnose the condition as labral tear with delamination and the calcified part of the rectus femoris. Also here is another view. So I start firstly with the extracompartmental part. I start peripherally. I develop my place through the proximal anterolateral view as a visualizing portal. This is the right hip, and operating just using direct portals with the augmentation of the radio X-rays with us. And I develop the calcified part and debride it. Now I'm visualizing from the proximal anterolateral and working from proximal to that, and then exchange the viewing portals to working from the proximal anterolateral portal. Then I'll continue to use curved osteotome and clarify the point of the rectus with tap hammering, few hammering, just to release it, as you see here. And after a while, it is completely released, and take it in. Use a grasper to take it as one fragment. Then go to the intracompartmental part, do the cam pathology. I'm operating now using the lateral portal for the instrumentation, proximal anterolateral portal for visualization inside the right hip. So we continue the cam rapidly and go to the most posterolateral part of the cam to confirm our complete recession of the cam. Then changing portals to see the pincer deformity. I'm now operating the distal anterolateral as a visualizing and using Weber to develop the paralabral recess and do a good recession of the pincer, test the labral mobility, and continue with the labral suturing using 105 suture knotless anchors to take one anchor and then take the other one by the same technique and drap the suture fiber tapes. Continue with the second at the same technique. Goes metal suture lasso. And from the direct lateral portal, I drop one of the metal suture and changing my working portal to work from the proximal anterolateral portal again once time. Take the metal suture with one fiber of this anchor, and then make a suture outside to inside. And after that, I take what I need from the tension. So I tension the labrum. After that, I'll do the second one, cutting the sutures and do radio frequency for the delamination that we found here. I'll go for some small tips. If I have a huge one like this, maybe I need to do a central axis portal first. I'll do the central compartment, do the cam pincer, and after that I do the lateral part using a very thin curved osteotome to release the part of the calcified part of the rectus femoris, not using a braided here to decrease the element of bleeding and also the free particles. And after I do complete release of the calcified part of the rectus femoris, I'll use a grasper for dragging as a one piece. We published this technique with our colleagues in Spain as a technique and follow-up minimum of 1 year with one case of revision in 6 patients. So this is the technique as an en bloc resection of calcified part of the rectus femoris. Thank you very much. Thank you.